Hi, my name is Dr. Ed Shahady, and we're here at the Cardiometabolic Risk Conference in Las Vegas. And I'm with Dr. Karl Doghramji. Karl is a professor of medicine, neurology, and psychiatry at the Jefferson School of Medicine in Philadelphia, and he's a Philadelphia Eagles fan, I believe. So, very good. Karl's going to be talking about sleep apnea and its relationship to cardiometabolic risk. Karl, as a primary care doc, who should I be thinking of? What should I be asking my people? Is there a certain type of patient I should be thinking of, or certain symptoms? So what do you advise?
Well, you know, Ed, we know that sleep apnea is a very common problem. Between 2 and 4% of the population has sleep apnea.
Right.
And in our populations, primary care physicians, it's even higher.
Right.
So it's estimated about 10 to 12% of our populations in medicine have sleep apnea.
Right.
It's more common in patients with cardiovascular conditions, CHF, coronary artery disease, stroke, people who have depression, sleepiness. So people with these comorbidities are much more likely to have apnea. And the other issue is that the presence of apnea, we're beginning to find out, complicates these other comorbidities and makes them worse. It increases the risk of diabetes, the risk of high blood pressure, the risk of a future hypertension, the future difficulties with stroke. And what's really interesting is that we're beginning to find out when we treat sleep apnea, identify and treat it, the risk of these other comorbidities decreases. So imagine we have people with high blood pressure, refractory hypertension. 2 drugs, 3 drugs, they're still hypertensive. We treat their sleep apnea. We might reduce that blood pressure down to normal. Or a person with glucose metabolism difficulties, high blood sugar. Blood sugar's not going down. Treat the apnea, blood sugar can go down. So very exciting stuff about sleep apnea. Now you asked me a question, who has apnea? Who should we be thinking of? How to identify apnea? Well, you know, the stereotypical apnea patient is the very obese male, middle-aged male with a large neck. And indeed, those people are at higher risk for apnea. But we now know that that's a very inaccurate way of establishing risk. There are about 4 or 8 parameters that impart a greater risk for apnea. One, history of snoring. If somebody says, you know, my spouse snores a lot, that's risk number 1. History of stoppages in breathing during sleep. You know, my husband has these gaps in breathing, these deathly silences in their sleep. That's number 2. If somebody has high levels of sleepiness, daytime sleepiness, excessive sleepiness, falling asleep at meetings, yawning a lot, tired, fatigued, you know, the doc, I'm tired kind of patient. And a person who has a body mass index above 35 and a history of high blood pressure, male, and a neck circumference more than around 14.5 inches. If you put all of those together, if 3 or more of those are positive, that's a very high risk for sleep apnea. 3 or more are positive. High risk. It's called the STOP scale. The STOP scale. So I would.
So what does that mean? STOP. It must mean something.
It means snoring. The O is observations of stopping breathing during sleep. The T is for tiredness or excessive sleepiness, and the P is for pressure or high blood pressure. Those 4.
So, but what if you know, if they're snoring and they have all those things, but what about just somebody just has cardiovascular? What if they're diabetic? Should I think all my diabetics might have sleep apnea, or maybe my uncontrolled diabetics, the same way with hypertensives, but they don't have any of the other symptoms?
I don't think so. I mean, I think you should think about apnea, but ask for the other symptoms. Now, I think that not all hypertensives and diabetics have apnea, obviously. Apnea is a contributing factor. But if you have somebody with sleep apnea, with let's say uncontrolled high blood pressure, and you've treated them with 2 or 3 drugs, and they're still not improving, they may be one of those few silent apnea patients who may have apnea, but you know, they don't have a wife who's sensitive enough to hear them snoring.
And they may not sleep together.
And they may not recognize the degree of their sleepiness.
Absolutely. No, they don't know they're falling asleep in the chair. But the spouse may not. So
think about it.
Absolutely. Well, no, all good thinking. So I've got to have a high suspicion of it. And the metabolic syndrome, obviously, this is a meeting on that. So people that have that, they're not well controlled or having difficulty controlling them, And if they have some of the symptoms, you know, with that. So what about treatment? Do they all of them need a big mask, you know, because my, oh, I don't want that mask.
Right. And you know, CPAP, as you know, Ed, has really revolutionized the treatment of sleep apnea.
Right.
It's simple, it's for many people easy to use, and it works really well. But you're absolutely right. Many people cannot tolerate CPAP. In fact, about 50% stop using it after the course of 1 year.
Right.
So we've got to have options.
Right.
And there are many options. For example, the oral appliances.
Okay.
These are dental devices that fit within the mouth. And
That has to be specially fitted by a dentist or something?
specially trained dentists.
All right.
There is a dental sleep society.
Okay.
Whose members are trained and licensed and certified, most of them certified in dental oral appliances. There are small devices which we can attach on the nostril, EPAP devices, which force air to be trapped in the nostril and therefore force the upper airway open. These are disposable, simple devices. Certainly upper airway surgery. I mean, you know, we don't want to refer everybody for surgery, but there are many surgical methods that truly work. And more recently, we have introduced about a year ago something called upper airway stimulation device. It's a pacer which fits within the skin of the chest. Same exact technology as the cardiac pacemakers, which in turn produce a signal which expands the upper airway every time patients inhale. So it's
only on the chest. It has nothing to do with oral.
Absolutely.
Yeah, excellent. So that's probably acceptable, more acceptable.
Yes.
Right. Pretty expensive?
Expensive. Insurance, thankfully, is covering in many cases.
Good.
And there are many other such treatments as well.
Right.
I would recommend that if a patient, and this is, I think, very important for us, for family medicine and primary care physicians, if a patient comes back and says, "Doc, you know, that mask is terrible, I can't tolerate it," please don't stop there. Have the patient go back to the center. They have the sleep center. These centers have access to many more treatments than just sleep apnea.
Well, very good. Thank you very much, Karl. That was very interesting. We appreciate your being here at the Cardiometabolic Conference.
Absolutely.